Thanks for the introduction. As most of you know, the healthcare workforce has been hit hard in the last year and a half. And as a physician that has practiced at a leading healthcare institution and also has a national perspective on what's happening broadly, I'm now reflecting on COVID-19, especially based on what I saw, experienced, learned, and really starting to think about what we need to do differently in the future to understand and prevent the inequities, the injustices in health that many of us have heard about on the news in the last year. So thinking about COVID-19, it was a preventable tragedy in terms of the scale of loss of life, the unjust impact it had on Black, Brown, and other historically disadvantaged bodies and communities. It was preventable in part because it was predictable, not just in terms of the likelihood of such a pandemic happening and general emergency preparedness, but also the predictable differential impact it would have on historically marginalized people and communities who have been systematically deprived of resources with centuries of neglect, exploitation, oppression, as the evidence shows. And yet many people were broadly caught off guard and many were still surprised by this differential impact. And impact is the key word here. This isn't about intentions. The majority of us have good to great intentions, but the evidence and science shows that even despite these great intentions, the impact of some of our decisions at the organizational and the individual levels are not meeting our intended desire to ensure full potential of optimal health for patients, for clients, for consumers, and at some moments are actually leading to harm. So the reality is that we as a country, as leaders, don't know widely our own history of racism and discrimination in this country or in healthcare, of how race has been used as a wedge to keep poor and working class white people in tension and opposition against other historically oppressed groups of color, and how all of this has and more has led to this moment of extreme division. For decades, we've operated in a color and identity blind way. Our narratives have been shaped by groups generally in power in service of the needs of a privileged few. Our history has been hidden and distorted to keep us separated and divided against each other. And ultimately, that prevents us from working in solidarity to anticipate and prevent such harms, or even to imagine a future state that works for all of us, not just a few of us. And I witnessed this firsthand, this fracturing and conflict with the first COVID-19 surge. COVID-19 was a pressure cooker in hospitals with stress, anxiety, uncertainty, fear, all brought to light in terms of the longstanding tensions and mistrust between groups by role, class, other factors. We saw nurses filing safety reports on physicians who got to wait outside the room and wondering why they had to go into the room when they got to wait outside. Clinicians questioning the ability and thoroughness of environmental services, and environmental services and transportation workers reporting resistance from some clinical staff and sharing what was then scarce personal protective equipment. And these themes emerged around fragmentation and power displays, top-down decision-making, information hoarding, breakdowns in communication, all reflecting this long-standing mistrust and tension between groups, often along class and identity lines. It also became clear that the impact and experience of COVID-19 was very different based on who you were and the neighborhood you came from. For example, it's a privilege to be able to safely quarantine and challenging when you live in a multifamily household or don't have a home or money for food or supplies. It's a privilege to be able to drive and park at work, which lowers your risk for exposure rather than having to take public transportation. It's a privilege to have a network of experts in the form of friends, family, and colleagues that many of us here probably enjoy. It's a privilege to not be exposed to all these countless social and structural determinants of health, which are not accidental, but intentionally designed into our systems, policies, and laws. And this really gets at Isabel Wilkerson's highly regarded work on the US caste system, which illustrates that it's a privilege to be born into a white body in an affluent circumstance in a society, our society, that artificially assigns and legally reinforces a social hierarchy for worth and opportunity based on race, class, and other factors. It's this lottery of life and this artificial social hierarchy and the position we find ourselves in at birth that largely shapes everything that comes after that. How we'll grow, live, work, thrive or not, get sick or not, and ultimately when and how we die from COVID-19 or otherwise. And healthcare is very much a part of this broken system. And we can trace this hierarchy all the way back to the birth of our nation, characterized by the genocide, the forced assimilation and relocation of Indigenous and Native American people to reservation lands, and slavery in the US, which is our most horrific and enduring innovation in the way it was carefully designed, adopted, diffused, normalized, and legitimized over time in healthcare, but also beyond. But it was uniquely operationalized in the US by justifying its existence through these racist, quasi-scientific medical theories. And these deeply entrenched myths and stereotypes have persisted to the present day, implicitly reinforcing a system of wealth and social inequality. And so we see today that innovation across sectors, and including in healthcare, broadly continues this legacy of exploitation of natural resources and people, focused primarily on maximizing profit and preferentially benefiting a privileged elite. Healthcare is currently structured and incentivized to deliver more services, and oftentimes high cost, low value services to those who can afford it. Social justice efforts are forced to operate within or contend with this profit driven system and always have to overcome this hurdle of what's the return on investment by leaders in power. And yet, our failure to anticipate and prevent the inequitable impacts of COVID-19 is one of the many stark reminders of the peril of doing this work, of doing any work when disconnected from core principles of morality, equity, and justice. And so when we look at the structure of healthcare today, we can't forget that in the last 400 plus years of American history, the majority of innovation has occurred in a time when we were disconnected from these principles, when we legalized the removal of lands, enslaved and segregated people that didn't look like those who controlled money and the financial and political systems. And that's had an impact on how successful we've been or have not been in ensuring that everyone has an opportunity to reach their full health potential. And we see those ripples in higher COVID-19 transmission rates, higher rates of deaths among people in these historically marginalized communities, especially Black, Latinx, and Indigenous. And this was also true for our employees at our hospital and others, because they live and come from these same communities. And so we saw our frontline healthcare workers, environmental services, food services, others were getting infected at up to 10 times the rate of our doctors and other more privileged healthcare professionals, not because they didn't take it seriously, they did, but because they had limited control and ability to protect themselves and the people they love relative to those with privilege. So what's our way forward? How do we begin to interrogate what we're doing? What do we need to do differently and innovatively? And as a start, we can get proximate to people. We can begin by getting close to the people who are being impacted, centering their voices and ideas, and transparently sharing information in dialogue. And that's what we did at our institution. We began sharing information with those employee groups on COVID-19 infection rates by identity, by geography, made available resources around housing, financial resources, domestic violence resources, childcare, ensuring access to PPE, personal protective equipment, COVID-19 testing, giving reassurance around job and income and personal leave time if they did test positive. And we had hundreds of sessions with over 1,000 staff in multiple languages, but it's one conversation that will always stick out for me. And it was this attendee, it was an environmental services employee who came up to me after and commented that she didn't know that she was allowed to be there. And she was referring to the space we were in. It was the large, elegant auditorium. And for some, like her, that was the first time they were there as an audience member and not as the person cleaning the room. Just as context, in 2018, the same auditorium used to have 31 all-male portraits of clinical department chairs, all of whom were white and men, one of whom was Asian. They were removed with a lot of controversy, but the homogeneity of these portraits was an undeniable reminder that US healthcare was and remains a casteocracy, not a meritocracy. Because for most of our institutional history, people of color, women, many others had no meaningful chance to get on those walls. And the story those portraits told was the wrong one about what excellence and belonging really looks like. And their removal created that essential space we needed to come together across differences to feel heard and respected. And we can deepen this proximity and belonging. So for example, through our work at the AMA, the American Medical Association, we're financially investing and partnering with communities in the west side of Chicago to make a dent in the enormous 16-year life expectancy gap between Chicago's Gold Coast and the Chicago's west side. It's led by community residents, healthcare institutions, educators, nonprofits, businesses, government agencies, and faith-based institutions, all working together in ways that would never have happened before in silos, and we're optimizing opportunities for innovation by focusing on 4 impact areas: economic vitality, health and healthcare, neighborhood and physical environment, and education. And this has led to an $8 million community development loan fund distributed to 300 plus borrowers, including entrepreneurs, small businesses, community-based organizations, with an additional 11 million leveraged for partnerships with community development, financial institutions, and outside sources that are raising funds. And so all of this is good and important, but will this be enough to reimagine and redesign, to dismantle and change the structures and how we've always done things? And the answer is probably not. Many of us are building this road of dismantling structural racism as we walk it, as Dr. Maybank says at the AMA. So to help us all, we need to ask and answer some fundamental questions. Who's benefiting and profiting and who's not from the choices we make and the solutions we put forward? Who's being burdened and who's not? Who's designing and who's being left out? What are the unintended consequences of our decisions and how do we mitigate those? How are we partnering differently and promoting sustainable solutions that center the voices, ideas, and people who've been historically left out? How do we change mindsets? How do we shift hearts? Ultimately, equity should be part of the fabric and the DNA of everything that we do. And we're moving in that direction as an organization and as a country in healthcare. And so we're advancing a national effort to coordinate and organize across sectors and within healthcare and the innovation ecosystem to operationalize equity and racial justice as a core mission and strategy, and to build a pipeline for the next generation of leaders to also lead equity and social justice efforts. And I'll close by reminding us that inequities are not random, they are produced. That means they can be undone. And in this inflection point in history, we have a chance to use our energy, our resources, our innovation to not only imagine, but actually achieve a state of equity and justice where we can all thrive. Thank you.